using, okay, but there's a line in front just for the demo.
Top one, yeah.
Yeah, top one. Yeah. Remember I said to you earlier about finding the high side, low side? Yeah. Yeah, have a line in front. Use the pencil, that's okay. Yeah. Now, in everything, there's probably a primary. Okay, the primary, you've got to try and find the primary, because patients' pains, when they have a bit of hip pain, a bit of knee pain, a bit of this pain, a bit of that pain, you've got to find the primary of all of it. Yeah, because all of this, ouch, this bit hurts and that bit hurts, yeah, it's probably the secondary problems. And there's a key somewhere, it's just up to you to find the key. So when you have like a lumbar pathology, if it's just in the lumbar and it's only been there early on, if you know what I mean, then it's more likely from lumbar spine. That's easy enough. But if it's been there ongoing, how long you had a back pain, it's been on and off for 10 years, that sort of thing, and you think, okay, yeah, and you've had lots of treatment, yeah, manipulation, mobilization on the lumbar, the more likely where they're treating is the wrong place. Okay? Then you need to be looking maybe at the position of the sacral, yeah, the position of the hip, yeah, and then the list just goes on from that. So no doubt if you've got a primary sacroiliac, when I use the word sacroiliac, then I have written some stuff down. This is more so my 4-day, because commonly this course is complemented by a 4-day course. Once you've done a 4-day pelvis, it makes perfect sense of why you do the next stage, you know what I mean? Yeah, rather, it doesn't matter if you do the other way around. But commonly people do the 4 days, then maybe want next time to do a 4-day and the manipulative course is the day after. Yeah, so when you think, okay, it makes perfect sense. Yeah. So when you're looking at the sacroiliac, so you've got the sacrum that's able to articulate within the ilium, but the ilium is able to articulate on the sacrum. So when you say the ilium is anterior on the sacrum and you say it's an SIJ, it's not correct, because it's the ilium that's dysfunctional on the sacrum, so it's an iliosacral dysfunction rather than a sacroiliac dysfunction. According to Greenman, Philip Greenman, you have something like 14 dysfunctions with the pelvis. I've written some on here. Anterior rotations, posterior rotations. Anterior, posterior shears, up slips, yeah, down slips. That's just to name a few. You've got the pubic area, the pubic symphysis. You can go inferior, and all the rest of it. And then you've got the sacrum, which can torsion within the ilium. So the sacrum, we don't use the word flexion, we don't use the word extension, unfortunately. We use the word to nod. So it's to nutate, and it's to counter-nutate. And then the sacrum is able to fix itself in that position, and the more nutated you are, the more extended the lumbar spine is. So if you're lordotic, the sacrum's nutated. And if you've got a flat back, the sacrum's counter-nutated. The sacrum, when you are walking and running, the ilia, the two ilia, the two innominate bones, are obviously rotating on an axis with the hip and leg. So as this rotates, the sacrum has to rotate within that axis as well. And you've got a lot of axis with the sacrum. You've got a right oblique, a left oblique. You've got 3 transverse axis, an AP axis, and a vertical axis. Yeah, just to name a few. And it just goes on. So, like the sacrum, remember I said you type 1 mechanic? What's that? Side bending and rotation to the opposite side. So the sacrum follows type 1 mechanic. Okay? So if you have a side bend to the right, yeah, then it rotates to the left. That is what it will do. But it can rotate. So when you feel in the sacrum, sometimes it'll feel deep on the right side. So the right side is fixed in nutation. However, the left side could be fixed in counter-nutation. So either the sacrum is rotated to the right, on what we call the right oblique axis, or it's rotated to the right. Yeah, in fact, let's go that way. So it's rotating left in this case. So if it's rotating that way, it's deep on the right, but it's rotating left. Okay? And it's either rotating left, yeah, on the right axis, or it's rotating left on the left axis. It's quite complex, the subject. Whatever the sacrum does, the lumbar typically does the opposite. So if you feel the lumbar spine is rotated to the right, it might well be that the sacrum is rotated to the left, causing the right rotation of the lumbar. So if you're going to correct the lumbar, you have to look at the sacrum. But in reality, you look at the sacrum before you look at the lumbar. Okay, even though you might not have sacral pain, you might need to look at the sacrum before you start treating the lumbar spine. However, I have been reading, because I'm writing a book on the subject, that some say that if you correct the lumbar, it can help the sacrum, and then some say, my theory is if you correct the sacrum, it helps the lumbar, because typically one has caused the other, and it's more likely A cause B rather than A cause B this way. It's more this going that way rather than that going that way. Yeah, because so many things influence it. We're talking about the long legs and short legs and stuff like that, but the sacrum in its rotation will give you an apparent short or long leg, yeah, rather than an anatomical long leg. Yeah, tightness in the adductors, weakness in the glutes will have we'll call a shift. You know, tightness in the QL, and you'll get all these side bendings and rotations in the spine. And to be honest, the list just goes on from there. Alright, so unfortunately it's never as straightforward as what it seems. Think about how long it takes to learn all this subject. And I'm a unit test. Right, but you know, you still learn. Okay. Alright, okay. Perfect. We have a left rotation in the lumbar. Alright, but remember I'm saying to you about the sacrum? Alright, we've got a right rotation in the sacrum. Okay, so shallow on this side, deep on this side, yeah? Yeah, so you can probably see by the rectus spina, it's follow on that side. Yeah? Alright, so L5, think about anatomically, PSIS comes to S2, iliacrest comes to L4. Yeah? Okay, so deep on that side, so it's rotated, so sacrum's doing a little bit of this, and the lumbar's doing a little bit of that. Yeah? In that case. But you're okay, Nick? Do you know any problems?
No, it's the tight right psoas probably.
Yeah, okay, but to be honest, you know, the psoas could be involved in all of what you see. Yeah, that sort of thing, because it could be pulling the lumbar, which is now causing the sacrum. So the psoas could be the primary, and the lumbar and the sacrum is the secondary. Alright, so now I haven't got time to go into all of that stuff. But you know, you're a detective, you have to try to work things out. Yeah, that's why you treat an area and you go, oh my god, don't know what you did, but stick with it because it's working. Yeah, and sometimes you treat and it doesn't help, you treat and it doesn't help, because you were treating the wrong thing. Yeah, that's what you're doing. When you look at the lower back, you have to think hips. Yeah, you have to check the hip. And you almost, when you've got knee pain, check the hips as well. So hips are really important to what you present with in here. Same with piriformis. Piriformis is normally the secondary, it's never the primary. You know, the piriformis is the reactive muscle. Okay, so it reacts as a result of something that's not quite right. But let's just go with this for a minute. Let's just stick with the lumbar, okay? Take out the pelvis for a minute, even though I wouldn't normally. Yeah, so find L5, come across to the transverse process, yeah, and then the right side goes further and the left side is shallower. So the left side is rotated. So we'll just say for now, we have a choice. Left side is fixed what? Closed, or right side is fixed? Open. Yeah. So if I got my patient into a sitting position, and the left side was fuller on that side, then I know the left side is fixed. Closed. If it was level, I know the right side is fixed. Open. Fuller. Yeah. I know it's easy when we talk about it now, isn't it? But when you're trying to think about it later, you're like, oh, God, what was it again? You'll probably be texting me saying, it's fixed closed on the left. No, 3 in the morning. It's fixed closed on the left. John, I could go say hello. Yeah. You're texting me at 8 in the morning rather than 3 in the morning. Yeah, but it's right in saying, if you wanted to, you could, because if you come up onto your elbows from there, he's extending, alright? So if he's extending, yeah, alright, so he's actually higher on the left, yeah? Okay, so if he's higher on the left, what's the problem?
Is that close
on
the left?
No.
No, the right.
Well done. Okay, so he's fixed open on the right.
So we do that again?
Yeah? Relax your head down. Tomas, I didn't want him to be that because I wanted to show you how to open a joint rather than trying to close a joint. Yeah? I was hoping he was going to level out. Right, so palpate in neutral, like you said to me earlier. Yeah, about palpate in neutral. Okay, so palpate in neutral, the left side is shallow, so it's a rotation left. Yep. But you don't know if it's fixed close on the left or fixed open on the right.
So when he's like that, it's essentially, if they're trying to process it, he's like that.
Okay. Yeah? Is that open or closed? Yeah. Yeah. Okay for now. Yeah.
Yeah.
All right. So because remember it's a type 2 mechanic anyway, so it's going to be either going to be side bent extended left or flex and rotated right. Yeah. To be open. So if you come up onto your elbows, where I ask him to extend, if the right side is stuck closed, then the left side is fixed closed. The right side will come back to neutral.
Yep.
Okay. However, if the right side is fixed open, then it's not going to, it's going to rotate on an axis on the left. So even though he's flexed, so in this case he will be flexed to the left, the right side is fixed open. So it will be FRS left, but the problem's on the right hand side, in this case. And it is hard, I wouldn't expect you, even my osteopathic students after 4 or 5 friends, 4 or 5 years ago, oh my god, it's still, you have to keep doing it. And unfortunately I haven't got the time to go through all of it for hours. Yeah? But what we're going to say is, for now, the dysfunctional side is up. Yeah? I know I'm going to say it's on this side, but thing is with osteopaths is, if you go and see them, they manipulate the left and they turn you around and they manipulate the right. If they say the top side is fixed open, fixed closed, they'll do a technique to open it, yeah? If a diagnosis is not quite right, as you open the top, what do you do to the bottom? Close it. Yeah, so it doesn't really matter 100%. Yeah, in terms of your palpation skills, because sometimes I go to manipulate the top one and it doesn't work because maybe my hypothesis is not quite right. Yeah, and it's not actually on the other side. Yeah. Okay, so it's like when I was first taught, I had to have like a tick box of 10. I had to have 7 ticks correct before I'd think about what the diagnosis is. Whereas my friend said you can't do that. You just have to just go with what you find and just treat what you find. And if your finger's closed, try and open it. If your finger's open, try and close it, and just go with it. Yeah. Because if you think about it too much, you almost confuse yourself. It's not working for you. Yeah. You've missed the 3 ticks, and those 3 ticks confused you then. All right. Because when you're looking at leg length discrepancies, this should be up, that should be up, the leg of this should be shorter, but actually the leg could be longer. Yeah, depending if it's a rotation or not. If it's up, it's shorter. If it's up, then the rotation is longer. The leg. It's just something. There's so much to think about. So what we're going to say, rest down. For now, okay, I'm saying that I'm incorrect. I'm saying that the left side, we're going to go with the left side is dysfunctional. Okay, and we're going to treat this left side, so the left side goes up. So the high side is up. Okay, just going to try and keep it simple. So this side, so I'm going to treat the side, even though I'm going to turn it around and do both sides. So does it really matter? No, not really. Yeah, I'm going to treat both sides. But this side is the side I'm going to look at. You can do a motion test. Have a lie on your side towards me.